Hello everyone, I'm Dr. Ayesha and I have been practicing medicine for the previous 5 years in Bangladesh. Moreover, I am a GMC registered doctor and currently I'm preparing for my Royal College exam and I'm going to share chronic obstructive pulmonary disease with you today. First of all, we'll discuss about etiology, then pathophysiology, then clinical feature, the diagnostic criteria of COPD according to NICE guideline. Then we'll discuss about management of COPD according to NICE guidelines. Also, we'll discuss long-term oxygen therapy and when we'll assess and when we'll offer, when we can't offer. We'll discuss all about that in this COPD series. Okay. So first of all, let's talk about what is COPD. So it is chronic obstructive pulmonary disease. It means it can contribute to chronic slow progressive airflow obstruction. So what are the causes behind this COPD? So smoking is the most important factor here. There should be history of more than 20 pack per year. Okay. And another cause is genetic, that is alpha-1 antitrypsin deficiency. There are other factors like air pollution, dust, coal, cotton, cadmium, cement, grain. Also low birth weight, premature baby, and also low socioeconomic status. Living in a low socioeconomic status can lead to COPD. And what factors can exacerbate COPD? So if you get any infection like bacterial or viral, then it may contribute to exacerbation. Also, smoking can contribute to exacerbation. So at exacerbation, we'll find raised level of eosinophil. Okay, let's talk about pathophysiology now. Okay, there will be inflammation which will lead to airway narrowing. Then there will be increased level of goblet cells. Also increase that means also lead to mucus secreting gland enlargement and vascular bed changes. So all of these ultimately lead to COPD, chronic obstructive pulmonary disease. Okay, that is chronic inflammation. There are two diseases like emphysema, bronchitis. Now we call it COPD. So what is emphysema? It is abnormal permanent dilatation of the air spaces distal to the terminal bronchiole. So here elastin is broken down and alveolar integrity is lost. Okay, and when we call bronchitis, there will be chronic productive cough for at least 3 months in 2 consecutive years. And at bronchitis, we will find increased level of mucus secretion and increased level of goblet cell, and which will ultimately lead to ciliary dysfunction. Now let's talk about clinical feature of COPD. So we'll find hyperinflation, then parsed lip breathing, and breath sound will be low or wheeze, and there may be flapping, tremor, weight loss, central cyanosis. So there are other factors like cough, dyspnea, then weight loss that can happen. I have just mentioned the things that you can forget. Okay, so what will happen in effective exacerbation of COPD? We'll find sputum color changes and new confusion may develop. And how we'll understand that COPD has progressed into cardiopulmonary or right heart failure? There will be increased level of JVP, and JVP will be raised. Then we'll find right ventricular heave, that is systolic parasternal heave, loud P2, tricuspid regurgitation, pulmonary edema, and hepatomegaly. Okay, so how will we diagnose the COPD according to NICE guideline? So age should be more than 35 years. Risk factor will need to be present like smoking or occupational exposure to certain dust or chemicals that we have mentioned before. And what are the symptoms? Symptoms like exertional shortness of breath, then chronic cough, wheeze, sputum, and chronic cough with sputum, wheeze, and there will be recurrent chest infection. And what are the investigation we can do? First of all, post bronchodilatory spirometry test. Here we will find FEV1 and FBC ratio less than 0.7. That is the obstructive picture. And FEV1, based on FEV1 percentage, we can diagnose the stage of COPD. And if it in COPD, normally it is less than 80%, but even if it is more than 80%, if there is symptoms of COPD, we can say that it is mild COPD. And if it is 50, then stage 2, that is moderate. If it is 30 to 49, then we will say that it is stage 3, severe, and less than 30, that is 4, very severe. So we can keep in mind or remember by 80, 50, 30, 30, less than 30, 80, 50, 30. So more than 80 is mild, 50 to 79 is moderate, 30 to 49 is severe, and less than 30 is very severe. And in emphysema, there will be total lung capacity or lung volume will be increased and transfusion factor will be reduced. Peak expiratory flow has limited value in COPD because it can underestimate the degree of airflow obstruction. So what are the other tests we can do other than post bronchodilator, reversibility, FEV1 FBC ratio, and FEV1? What are those tests? Like chest X-ray, what will find in chest X-ray? There will be hyperinflation, bulla, flat hemidiaphragm, and there will be feature of pulmonary hypertension like prominent vasculature. And CT chest. When we'll do CT chest, if the symptoms and there is no balance between symptoms and spirometric impairment, so there is disproportionate, there is no balance, then we'll do the CT chest. And also we'll need to do CT scan before assessing the suitability of lung volume reduction surgery. And we will also do BMI to check if there is any weight loss. Then we'll do arterial blood gas to identify respiratory failure type 1 or type 2. Then we'll do full blood count. NICE recommend doing full blood count in all COPD patients to rule out secondary polycythemia. And alpha-1 antitrypsin deficiency, here if patient is young, there is no history of smoking and family history of COPD, in that case we'll do alpha-1 antitrypsin level. And we'll also do the ECG. What we'll find? We'll find P pulmonary, right axis deviation, right bundle branch block. Okay. Moreover, we'll do sputum culture. What we'll find here? We may find different organism. Most importantly is high. That is Haemophilus influenzae. Second, Streptococcus pneumoniae. And there are other organisms that can contribute. That is Staph aureus, then Moraxella catarrhalis, and gram-negative organism. Now let's talk about management of COPD. There are some general measures we can take. That is pulmonary rehabilitation. But when we'll do pulmonary rehabilitation, when patients are functionally disabled by the COPD, that means there is a Medical Research Council grade 3 or more than 3. In that case, we'll offer pulmonary rehabilitation. Also, we'll provide chest physiotherapy if there is excessive mucus production, and we'll advise not to smoke. Then smoking cessation can be achieved by offering nicotine replacement therapy, varenicline, bupropion. Also, we can provide domiciliary non-invasive ventilation. So there is a history of if there is a history of non-invasive ventilation or invasive ventilation, and there is hypercapnia, ongoing hypercapnia, despite giving then patient is on oxygen, but patient is acidotic and carbon dioxide is rising. In that case, we'll offer domiciliary non-invasive ventilation. And vaccine. Regarding vaccine, influenza annually and pneumococcal one-off. But when we'll provide pneumococcal 5 yearly if patient has splenectomy done or patient have hypersplenia syndrome. In that case, we may need to give 5 yearly, but usually it's one-off. Okay. Now we'll discuss about management of stepwise management of COPD according to NICE guideline. So first of all, we'll need to provide bronchodilator that is short-acting SABA or SAMA. Okay, SABA is like salbutamol and SAMA is ipratropium. Okay, we can use any of that, SABA or SAMA. And then we'll identify if patient has asthmatic feature or patient have steroid response. Okay, patient responding to steroid or steroid responsiveness. If it is yes, then we will provide SABA or SAMA plus LABA plus ICS, LABA and ICS, inhaled corticosteroid. Okay. Then if patient is not responsive to steroid, there is no asthmatic feature, we'll provide SABA plus LABA plus LAMA. If we add LAMA, we must change SAMA to SABA. Okay, we do not need to give SAMA LABA together. So we can provide SABA and LABA together. So SABA LABA LAMA. Then if both are not controlled, steroid responsive and both, then we'll need to provide triple therapy, that is SABA plus LABA LAMA ICS, LABA LAMA ICS. So it is triple therapy. SABA plus LABA LAMA ICS, that is triple therapy. So if patient can't tolerate ICS, then we may need to provide second step again, like we need to stop the ICS. Only we'll provide SABA LABA LAMA, LABA LAMA SABA. Okay. There are other options that we can use, but before that, I want to tell you the asthmatic or steroid responsive features. Like if there is a history of asthma or atrophy, and there is increased level of plasma eosinophil count, and there is variation in FEV1 that is more than 400 ml, and diurnal variation of peak expiratory flow that is more than 20%. And there are other options that I have mentioned. I'll say one by one. First of all, we can provide oral theophylline, then oral prophylactic, antibiotics, mucolytics, corpulmonary, also long-term oxygen therapy. We'll talk about now. Like oral theophylline, when we'll provide oral theophylline. So if after giving short-acting and long-acting bronchodilator, it is still not helping, in that case, we'll provide oral theophylline. And who can't tolerate or use inhaled therapy, we can use oral theophylline in that time. But if we introduce macrolide or fluoroquinolone, we need to reduce the dose. Okay, macrolide, fluoroquinolone. Okay. And what antibiotic prophylaxis we can give? We can provide azithromycin. And when? If patient have stopped smoking, patient is on, despite taking optimized standard treatment, patient is having exacerbation. Patient is not smoking, patient are on optimized standard treatment, but is still having exacerbation. In that case, we need to provide oral prophylactic antibiotics. And also, if before giving oral antibiotic, we need to do CT thorax to rule out bronchiectasis Also, sputum CS, sputum culture sensitivity to rule out atypical infection or tuberculosis. We'll do liver function test. Most importantly, we'll do ECG to exclude long QT syndrome, because azithromycin can lead to long QT syndrome. Okay. Third option, we can use mucolytics. When patient is having chronic productive cough, in that case, we'll consider mucolytics, and we'll continue if there is improvement after using this. And we have mentioned the feature of carpalmonally. We can use loop diuretics in carpalmonally to reduce the edema. Also, we can use long-term oxygen therapy. We can consider. Okay. So factors that improve the survival. First of all, most importantly, smoking cessation, then long-term oxygen therapy and lung volume reduction surgery. Now we'll talk about long-term oxygen therapy. When we can provide long-term oxygen therapy, and what patient we need to assess, how we'll assess, and when we'll not offer long-term oxygen therapy, and there is some risk assessment before long-term oxygen therapy. So how long we'll provide long-term oxygen therapy? So every day we need to introduce at least 15 hours a day. Okay, fixed supply, at least 15 hours a day through a oxygen concentrator. Okay, so when we'll assess the patient for the need of long-term oxygen therapy, if patient is having stage 4 COPD, that is very severe airflow obstruction, FEV1 less than 30%, then we'll assess the patient. But we'll also consider if patient is having stage 3 COPD, that is FEV1 30 to 49% and severe airflow obstruction. Also cyanosis, polycythemia, peripheral edema, raised JBP, oxygen saturation less than 92. In that case, we'll assess the need for long-term oxygen therapy. And how we'll assess? When we'll assess? So patient is having stable COPD on optimal management, and we'll do ABZ on 2 patient 3 weeks apart. Okay, and we'll offer long-term oxygen therapy if partial pressure of oxygen less than 7.3 kilopascal, and or partial pressure of oxygen is 7.3 to 8, but also having one of the following, like secondary polycythemia or peripheral edema or pulmonary hypertension. Okay. So when we'll not offer long-term oxygen therapy if patient continue to smoke despite giving smoking cessation advice and referral to specialist stop smoking services. And moreover, we'll need to do risk assessment before long-term oxygen therapy, as there is risk of fall, if there is risk of fall, tripping over the instrument, then if there is risk of burns, fires, and if there is risk of smoking, anyone in the house, okay, even e-cigarette, we can't offer long-term oxygen therapy in that case. Thank you very much for watching our videos, and if you have any suggestion, do not forget to leave a feedback in the comment section. Bye bye, see you in the next video.